CPSO presents In Dialogue, a podcast series where we speak to health system experts on issues related to medical regulation, the delivery of quality care, physician wellness, and initiatives to address bias and discrimination in healthcare.
Welcome to part 2 of our two-part conversation with Dr. Jonathan Wong.
When discussing supporting unhoused populations, many people have referred to the idea that housing is a fundamental part of healthcare, and without it, health concerns continue to worsen. In other words, housing is healthcare. It is critical to people's success and health outcomes. What are your thoughts on this? Do you agree generally that, a lot of where this can start is actually getting proper housing in place?
I totally agree that it is a fundamental part. I think housing is indeed healthcare and healthful, and really without the safety and security of housing, it's hard to work on one's mental health or substance use or any other health concern, be it like high blood pressure or diabetes. Unfortunately, as physicians, it's not like I can write a prescription for housing, but can certainly call on policymakers and governments to make housing more affordable and provide an ample variety of housing options. But it's obviously, it's not that simple though, right? Like it's not just a question of affordability or increasing supply. Supply affordability, definitely issues, but everyone is very different. We all have different priorities and circumstances, abilities to function independently, right? You can't just like plop someone into a house and expect someone to suddenly be completely independent and be able to maintain their housing, right? Like there also needs to be a plethora of resources available to support people who might need it post-housing. So I think typically like social workers, case managers, people who work to get people into housing, they might only support someone for like another 3 to 6 months. And, I don't know, what does that mean? What are we doing? Like, how are we facilitating sort of safe transitions into housing? And how are we preventing re-homelessness? What is the criteria to, as a case manager or a housing worker, like what's the criteria to safely discharge? And I love case managers. Like, I think they're worth their weight in gold or Bitcoin, whatever you want to weigh them in. But I know housing is very, in this day and age, right? Like, it's very hard to come by. And people won't always have the best choice. But I think, at least in some of the folks that I've worked with who have eventually gotten housing, they end up being sort of uprooted from their community, where their supports are, where their doctor, their nurse practitioner, and their community, their friends, their support network, right? And I feel like we always need to ask, well, what works for you, right? How can we put you in the best position to succeed and to maintain housing and not be evicted after a year or two, right? Like there's someone that we recently met on street medicine, just sort of panning on the corner, is actually housed. I have no idea how he managed to get housed, but our nurse did a home visit and his place is a mess. And I don't know how much longer he's going to last there, right? Like at what point are our neighbors starting to complain about certain things, right? And then eventually like the person's going to get evicted. And the person is not currently supported by a case manager, but desperately needs one, right? So there just needs to be more of that supportive housing style, resource available to folks, I think. Not everyone needs it, of course, but as I mentioned earlier, we need to think about like what works for this person. And another consideration for housing, and to the point of like, we can't just plop someone in, but if someone is using substances too, right? Like similar to the earlier hotel shelter comment that I made, like people fatally overdosing in hotel rooms. Like if we put someone in there in an apartment, are they at risk of fatally overdosing? Like, can we bring more addiction supports to them locally? Are there safe injection sites nearby or on site? Like, if anything, the pandemic revealed that, like, it's not COVID-19 killing people, right? It's the opioid crisis. It's fentanyl. It's these extremely dangerous and toxic street drugs. It's all a challenge. Housing is definitely a part of it. I also wanted to comment on the ability to maintain housing and not have your unit taken over. Like, I've seen cases where someone gets housing and their unit gets taken over by other people and they're essentially like locked out of their own home, but then because it's their name on, the rent, they're the ones being eventually evicted. It's housing and sort of how can we durably keep folks housed and prevent re-homelessness.
Switching gears a little bit to talk about the healthcare end of things, what role can physicians play in ensuring that these marginalized populations don't fall through the cracks when they actively seek out healthcare, whether at a hospital or other facility?
Yeah, so it's all going to be harm reduction focused and trauma informed. It's not just the doctor themselves. Whatever roles physicians can play in terms of organizational change and culture change and sort of training and coaching and informing people that you work with, like everyone should really have an understanding of these principles. Sometimes it takes great effort and sometimes pains, I guess, to get someone into a tertiary care center. And a lot of work gets done for this. And to have that, like, for instance, I had this, I'm still working with this particular patient, but, has uncontrolled diabetes and a diabetic foot ulcer and has a bone infection and absolutely needs to go to the hospital. And like, there's a lot of encouragement to get them there. And to have that sort of derailed by someone who isn't maybe as patient or can come off as judgy or dismissive will absolutely cause some folks to leave without even being seen by a physician, right? So, and I mean, I get that emergencies are busy, everyone is, overworked and tired, and I'm definitely not disparaging anyone, but I mean, just basic kindness, gentleness, respectfulness goes a long way in making people feel dignified, right? I don't know if there's any way to fast track people, but I think generally anything that physicians, as in their own practice when seeing folks who are coming into hospital, or as leaders in the hospital, can do to make people feel more comfortable. Hospitals are often traumatizing places, as you know. Sometimes the sight of security, right, can be triggering, right? Maybe, someone, especially during the pandemic, no one was ever allowed, but I think sometimes people's community and their friends, their peers are not allowed to come if they aren't family, but like, can we allow people's friends to come and visit and support them, right? There are like a good number of places that have like St. Michael's Hospital, for instance, downtown. I don't know what the title is, but they have folks who in their Emerge specifically work with people who are experiencing homelessness or are more vulnerable to make them more comfortable. And also, like, on their inpatient unit, they have these homeless outreach workers. I think all of these pieces are critical, right? And I think as physicians, the transitions of care piece is also very key in sort of preventing people from falling through the cracks. All too often, they're, at least from the outside looking in, I mean, I don't know that people are content to allow people to leave against medical advice, but it happens very often, unfortunately. Can hospitals change such that, if there's capacity on your inpatient unit, can you leave your bed open for 24, maybe 48 hours to allow someone to come back, like a homeless outreach worker allowed to go and chase them down and try and bring them back, right? If someone's using substances, can you be a little aggressive in sort of your safe opioid supply prescribing, so long as it doesn't sort of interfere with whatever else is going on clinically, Like, there's this addictions doctor at St. Mike's. She is wonderful, and she's also like thinking about, well, how do I get this person a TV so I can, like, the TV cable subscription in their rooms to make them more comfortable? Or do they need double portion meals? Do they need their insures? Are they on enough safe opioid supply? Like, sort of all those things to make people feel comfortable. Yeah, so that they don't leave against medical advice, ultimately. I think I was getting into the transition of the care piece, but sometimes people get discharged with no clear plan, and as a primarily outpatient physician, like, it's sort of hard to follow on the outside and sort of what's been communicated. And when you talk to the patient, sometimes they're like, well, no one really ever told me this or that. And you read some of the discharge summaries, and it's like, DC or discharge home, right? Well, did we ever even check on the patient's housing status? Like, if we knew that they were experiencing homelessness, how could we ensure that follow-up doesn't get dropped, right? And I know, like, usually it's sort of the intake person that might take down phone number and email address or even their physical address, but like somehow it doesn't always get to the care team that, hey, maybe like I do need to call someone's shelter and sort of get a little more collateral. And like, these things do happen, but sometimes it does unfortunately get missed in spite of our best efforts, right? I guess it's usually that Swiss cheese model where multiple things happen and then a bad event happens.
Do you know of any resources or support tools, maybe some training that might help physicians and institutions address these kinds of issues and create more welcoming, safer, more inclusive spaces for these patients who are especially vulnerable?
I think it does come down to health human resourcing. Like, I get that hospitals are so stretched, but I think this is an area that we definitely need to invest in as a system. And again, it sort of comes down to where the government's going to put their money.
I know here at CPSO, like we've done training modules as part of the Rainbow Health Network for treating LGBTQ communities and the Sanyas training, cultural safety training for Indigenous communities.
Oh, yeah.
And these tools
That's a good one.
yeah, and these tools are incredibly helpful in just kind of like pivoting your thinking and really considering a number of issues that you may not have considered before in your work. But it sounds like we need something equivalent for homelessness and precariously housed populations and all the rest, the kind of training that is able to really help people work through these issues and drive that kind of more welcoming and safe environment that you're talking about.
Yeah, totally. I agree.
Yeah. What do you consider to be the greatest obstacle currently facing unhoused populations, and how is it impacting their health?
So I would say probably poor policy and broadly the precariousness of our social safety net. I mean, I know we're doing better than our U.S. counterparts, but you can have the most robust program designed on paper with the best health human resources out there. But if policies around housing, around income, if they don't align to make it possible for people to escape poverty and homelessness, then even the most well-designed program will fail, right? So, as I mentioned, that housing options, they need to work for people. I already mentioned, like, without the safety and security of housing, it's really hard to work on one's health. And, no matter how many medications I prescribe, like, the housing piece is crucial. I think greater income supports, like, I think ODSP, Ontario Disability Support Program, is really a drop in the buckets, particularly for folks who live in Toronto or sort of one of the bigger cities in Ontario. I believe someone as a single person can take in like $1,200 or so, $1,225 or something. But $700, around $700 is earmarked for basic needs, and then another $500 for shelter allowance. But if you are living outside, they aren't going to give you the shelter allowance because you're not staying in a shelter. So all you're getting is really $700 per month for your quote unquote basic needs. And like, given the cost of living here and inflationary pressures, like there's no way, right, that meets people's basic needs. And I don't think they've really increased ODSP payments. And I think at one point they were talking about possibly making ODSP harder to come by, which would definitely be a backward step. So all of these policy decisions are like have a very, very big and negative, or can have a big and negative impact on people that we serve. I think outside of the policy stuff, like I think addictions, I know you only asked for one, but addiction support is a big one. There's just like a total, even though, as I mentioned earlier, like I think Toronto generally has trained up a lot of physicians to be able to provide more meaningful addiction support, but there's still a big gap in that there are no medical detoxes available that are easy to get into. In general, the amount of need that there is in this area is just so vast and unmet. And of course, like if you are struggling with substance use, it is so challenging to engage in other aspects of your health care because like a lot of time is basically spent obtaining, using, and recovering from substance use, right? So it's just really sad to see. And, I hope I'm not painting a picture that like every person who is homeless is a substance user. Like that's definitely not the case. And just really wanting to stress that substance use is often like, I would say like all the time used as a coping mechanism, right? For like this like very, very extensive and terrible traumas that have happened to people over the course of their lives.
Yeah, no, I think there's something that we've touched on in a couple other conversations that we've had about, again, it speaks to that judgment-free way of treating patients and really meeting them where they are and understanding, just the extent of that trauma and the various coping mechanisms that they've developed, whether that involves substance use or something else, right? Any closing comments or thoughts for the future? What are some of the things that you hope for yourself, for your colleagues, for your patients, and for our health system overall?
I guess I just hope that we collectively as healthcare providers would see the moral imperative that we have to not neglect people who are living on the street or have had an experience of homelessness and really work towards fighting all this stigma that people face, right? People are shamed and blamed for the choices that they make. But I think when it comes down to it, people are just making the best choice that they can, given the circumstances that they're in. I think we could all probably say that there's a lot that we cannot individually control, and like it's definitely true of folks who are experiencing homelessness. Like there's a ton more that they can't control, and yeah, I just hope that we would be able to educate and inform and love on others, and I think those things will sort of combat ignorance or fear around working with people who are experiencing homelessness, because I think our greatest asset is really trust, the wisdom, the love that we can extend to folks, and sort of letting them know that they aren't forgotten and that they are of inherent value as human beings.
Well,
Some of the most beautiful and skilled and courageous and resilient and generous people I've met in my lifetime are people who have had or are currently experiencing homelessness.
Well, I think that's an incredible note to end on. I think that you've given us so much to think about, to consider, to pass along to colleagues in the health space, and armed us with some really important information that's going to help us to move the needle and make improvements to the system that are going to help these populations. I think that's something that we all hope we can do, and I really appreciate the time that you've taken to share these stories with us and your perspective on all this. It's really quite something.
Thank you so much for having me, and it was so great to chat with you.
Thanks so much.
Hope you enjoyed part 2 of our conversation with Dr. Johnny. If you haven't yet, please check out part 1, which was released in November last year.
Thank you for joining us. Please visit CPSO Dialogue for more in-depth discussions about healthcare.